Today's topic of discussion is Tapes Dorsalis. This is my seminar for today. I'm your presenter, Dr. Siddharth, and my moderator is Dr. Shoaib. The learning objectives of this seminar will be the late neurological manifestation of syphilis, namely Tapes Dorsalis, the mechanism of neuronal injury, identifying the clinical manifestations of Tapes Dorsalis, diagnosis of Tapes Dorsalis, and the management of Tapes Dorsalis. Coming to the causative organism for Tapes dorsalis or syphilis is Treponema pallidum, which is a spirochete. Neurosyphilis occurs when there is CNS infection occurring by Treponema pallidum. Once infected, spontaneous resolution may occur in some cases without an inflammatory response, and in other cases, spontaneous resolution may occur after a transient meningitis. Coming to the epidemiology, before the advent of antibiotics, about 25 to 30% patients developed Tapes dorsalis, and these are 25 to 30% of the patients who had syphilis developed Tapes dorsalis. But with the advent of antibiotics, asymptomatic and early neurosyphilis are more common, and these are also common only in patients who are suffering from HIV and have a low CD4 count. Coming to the neurosyphilis syndromes, they've been distinguished into early and late syndromes. The early on the neurosyphilis syndromes, the person may be asymptomatic. Secondly, they may be early symptomatic, or third, they may have meningovasculitis. Late neurosyphilis includes parenchymal involvement, of which Tapes dorsalis is a part, or the formation of CNS gammata. The natural history of neurosyphilis is as mentioned here. There is first of all CNS invasion, after which there may be a natural clearance of the organism, or in the early stages the patient may develop transient meningitis. In the transient meningitis also, in the initial phases it may be asymptomatic, which is the persistent meningitis phase, and may get cleared. In case it persists, it may develop early symptomatic neurosyphilis, which may be present over weeks to months to years and take this much amount of time to present, wherein we have symptomatic meningitis with typical symptoms of meningitis such as headache, stiffness of the neck, nausea and vomiting, cranial neuropathy and ocular diseases. And in certain cases we may have meningovascular symptoms, wherein patients may have meningitis, and due to vascular involvement they may even develop stroke or transverse myelitis. Third, we have late symptomatic neurosyphilis, which may take years and decades to develop. There is a first group that has general paresis, dementia, paralytica, and personality changes. And secondly, we have spinal cord involvement, wherein patients may develop Tapes dorsalis, will have sensory ataxia, visual symptoms, and incontinence. The pathophysiology of neurosyphilis. The invasion of CSF occurs in the early course of neurosyphilis. The main pathology is perivascular inflammatory response, in which when the meninges are involved, there may be meningeal hypertrophy, which may later lead to formation of gammata, and in case the blood vessels are involved, they may develop inflammation, hence they may develop arthritis or thrombosis, which may further lead to stroke. There may be a spontaneous resolution over time of the meningeal involvement. Coming to chronic inflammation, this is the part which results in late neurosyphilis. Parenchymal involvement may be present, which may lead to neuronal injury, degeneration, and later gliosis, and it may manifest as dementia paralytica and Tapes dorsalis. Tapes dorsalis. The lesions are concentrated in the dorsal root and the dorsal column of the lower thoracic or the lumbospine vertebra. I've shaded a part of the diagram, the anatomy, where you can see red in color, that is the dorsal column and the dorsal roots are the main parts affected in Tapes dorsalis. There is a lymphocytic plasma infiltration of preganglionic portion, which later leads to atrophy of the same. There is diffuse meningeal thickening dorsally and diffuse myelination and degeneration of dorsal roots and columns. Coming to the symptoms, there is a very typical symptom of Tapes dorsalis is lancinating pains, which is characterized by sudden, brief, severe stabs of pain that may affect the limbs, the back or the face, and may last for few minutes to several days. There is sensory ataxia, because of which the patient has a wide-based gait and has a slapping kind of gait, wherein the patient needs to hear the Here his foot stopping the ground in order to balance himself. There is loss of coordination along with loss of lower limb reflexes. There is joint damage, especially in knees. Uh, this also is inclusive of Charcot's joint, which are neuropathic joints with the erythema, pain, etc. There is atonic bladder with urinary retention and overflow incontinence, and there may also be vision changes, which may be due to optic atrophy, and a very typical symptom of a very typical sign rather of neurosyphilis is ARGYLL-ROBERTSON pupil. ARGYLL-ROBERTSON pupil is a pupillary irregularities which are very common in patients with Tabes dorsalis. It accounts for approximately almost a half of all the pupillary abnormalities in patients with Tabes dorsalis. An ARGYLL-ROBERTSON pupil is small, irregular. It does not respond to light, but contracts normally to accommodation and convergence, dilates imperfectly to mediatrix, and does not dilate in response to painful stimulus. Hence, in brief, it can be said that the light reflex is absent, but accommodation reflex is present in an ARGYLL-ROBERTSON pupil. Coming to the diagnostic algorithm for Tabes dorsalis or neurosyphilis in particular has been distinguished into two parts, wherein it has been segregated by patients who are having HIV or patients without HIV. First, we'll be discussing patients with HIV. So, in patients with syphilis and without an HIV infection, suspected neurosyphilis is in a patient without HIV infection, wherein we have to get the serum FTA-ABS, which is the fluorescent treponemal antibody absorption test, or the TPPA, that is the treponema pallidum particle agglutination assay, or the TPEIA or CIA, that is treponema pallidum chemoluminescence assay. In case it is non-reactive, then the patient does not have neurosyphilis. In case the patient is reactive for these, we'll have to go ahead and examine the patient and evaluate him for his various symptoms. In case the patient has neurologic, otologic or ocular symptoms which are consistent with NS, we again segregate them into two parts, wherein the patient has only neurological symptoms, or if the patient has otologic or ocular associated involvement. In case there is neurological involvement, from the left we can see, we directly have to go ahead with the lumbar puncture to determine the baseline CSF abnormalities, and the need for diagnosis and the diagnosis and the need for treatment will be based on the CSF study, which we'll come to in a while. Then again, the patients who are having ocular or otologic involvement, if there is a clear alternate diagnosis for otologic or ocular involvement, and the we'll then test if the neurological symptoms are consistent with NS. In case they are not consistent with NS, then there is less chance that it will be neurosyphilis. In case they are consistent with NS, then for definite diagnosis we'll have to go ahead with the lumbar puncture. In case otosyphilis or ocular syphilis is confirmed or not ruled out, then once again we have to go ahead with an LPN check for CSF abnormalities. If it is positive, then we have to treat for NS. Now, first of all, when we are doing lumbar puncture, the fluid has to be sent for VDRL. If it is reactive, we directly start treatment for neurosyphilis. In case it is non-reactive, we look for the number of WBCs. If the WBC count in CSF is less than 5 cells per microliter, which if it is more than 5 cells per microliter, we go ahead and treat for neurosyphilis. In case it is less than 5 cells per microliter, we go ahead and examine the amount of CSF protein. If it is more than 14 milligrams per deciliter, then we have to start treatment for neurosyphilis. In case it is less than 45 milligrams per deciliter, there is no evidence of neurosyphilis. Now coming to neurosyphilis with HIV, the rest of the algorithm remains the same. There are just very few differences that come in place with an HIV infection. So in a person with HIV infection, we again go ahead with the simple tests, that is fluorescent treponemal antibody absorption test, then treponema pallidum particle agglutination assay test, and treponema pallidum immunochemoluminescence assay test. In case they are non-reactive, then there is no NS. In case they are reactive, then we again go ahead with patients who are having neurologic, otologic or ocular symptoms which are consistent with NS. So in patients with the HIV, the only difference is that they may present with no symptoms whatsoever. So the algorithm for the patients with HIV having neurological symptoms or otologic or ocular symptoms remains the same. We just have a different column for patients who are having no symptoms. In case those patients with no symptoms have an RPR value, that is the rapid plasma reagent test value of more than 1:32, or a CD4 count of less than 350 per microliter, or an HIV RNA load of more than 50 copies per ml, or the patients who are not taking any retroviral drugs. In case the answer to all these questions is no, then there is no evidence of NS. In case the answer to any of these questions is yes, then there is the patient should undergo a lumbar puncture and CSF analysis to look for diagnosis of syphilis once again. So once again, as we had discussed in the patients without HIV, everything zeroes down to patients undergoing a CSF examination. So in this examination, the first thing to do is CSF VDRL. In case it is reactive, we go ahead with the treatment for NS. In case it is non-reactive, the second thing we look at is the CSF WBC count. If it is less than 5 micromoles per liter, then there is no NS. In case it is more than 20 micromoles per liter, we treat the patients for NS. In case it is between 6 to 20 micromoles per liter, then again we have to take into consideration the number of CD4 cells. If the CD4 cells are less than 200 per microliter, and the HIV RNA copies are less than 50 copies per ml, and the patient is taking ARVs. In case the answer to all these is yes, then the patient has to be treated for NS. In case the answer for all these is no, the patient has to undergo CSF FTA ABS, that is the fluorescent troponomal antibody absorption test. In case it is found to be reactive, then the patient has to be treated for neurosyphilis. In case it is not reactive, then the patient has no neurosyphilis. Coming to the treatment, the standard regimens recommended by the Centers for Disease Control and Prevention guidelines for the treatment of neurosyphilis, including ocular and otosyphilis, are aqueous crystalline penicillin G, 18 to 24 million units per day, administered 3 to 4 million units IV every 4 hours, or 18 to 24 million units daily as a continuous infusion for 10 to 14 days. Or the patient may receive procaine penicillin G, 2.4 million units IM once daily, plus probenecid, that is 500 mg orally 4 times a day for 10 to 14 days again. Alternatively, the patients who have penicillin allergy can receive ceftriaxone 2 gram IV once a day for 10 to 14 days, but then again we have to be a little watchful for cross reactivity. Other patients may receive high dose doxycycline, 200 mg oral twice daily for around 21 to 28 days. But none of these above treatments, that is ceftriaxone and doxycycline, have been recommended by CDC or European guidelines, but are still widely practiced everywhere. These are my references. Thank you.